Hello, everybody. My name is Jose Games, working in South Texas. I have in fact, this happened this week. I have a kid who is currently 10 years old. He has a congenital renal hyperplasia. And the last time that he did a bone age, it was back in October. The bone age is already 15 years. This kid, besides the medications that I have for the congenital renal hyperplasia, the hydro and the fluorocortisone, I also diagnosed him with a central precocious puberty trigger, most likely CAH, when he was 7 and a half, and I started with Triptolur back at that time, and then moved on to Lupron. His bone has always been advanced for the last 3 times that I've been checking for like 5 years. Now, last week, mom comes to me. I also have him in anastrozole, trying to decrease a little bit the advance. Now, Matt is asking me, what about growth hormone? So that's the question that I have. I've been trying to look up anything, but I really don't have a clear answer. I told mom, you know what? I'm gonna look into it. That taking advantage that I'm going to go to the meeting, trying to put it to the experts, and trying to have an answer for you next week. So that's my case.
And maybe when I was sitting down, just to ask a couple of things. How old is the patient now? Did you say?
Now he's 10.
Okay. And how long has he been? He has salt wasting classification.
Oh, since he was born. I inherited this kid from the previous endocrinologist down in the area. And he's, of course, compliance has been always an issue, right? Maybe over the last couple of years, mom has been more tight with compliance, and his numbers are better now. But again, it's just the bone age advancement is just giving a really, really bad high prediction.
And did I hear you say that his bone age is 15?
The bone age is 15.
And that's with very aggressive treatment, it sounds like. Who was the Lupron stop?
So I was giving him Triptodor, but because they changed insurance, they changed job in April last year. So the last shot of Triptodor was kind of in April. So supposedly we're off by October, kind of. So, and just last week I was able to give him Lupron because of insurance issues. So he's been on Triptodor for, I would say, 2 years. He was, and now we're giving Lupron.
And then when did you add an anastrozole?
3 or 4 years ago.
I'm going to give the mic if the audience can't hear the questions. So I'm going to get my workout today.
Okay, back and forth.
I want to make sure that
You can count the steps.
I'm sorry, I was also trying to project too. My question was, when did you start an anastrozole? Here, I'll just come closer.
Okay.
You can stand in front of the computer.
Okay. Okay, so maybe when he was around 8, I started anastrozole.
Okay. And what therapy is he on right now? What's his glucocorticoid?
He's on hydrocortisone 10 milligrams TID,
Okay.
and he's in the fluorocortisone 0.1 milligram once a day.
Okay. And what the hydrocortisone, what are the doses about how much per meter squared?
It's around 20. It's around 20, yeah.
Is he, what's his velocity of growth like on the therapy? I'm assuming it's not great.
It's like around 5 centimeters per year. It's not so bad. He's been growing. And in fact, I have the growth chart right here. I don't know if at some point I can show. I don't know. Doesn't look like it now. No. But he have a good growth rate. He's not been impaired. It's been over the last 3 or 4 years that I have this kid. Is growing in a constant rate, maybe 5 to 6 centimeters per year. So.
And then the last in the ton of questions that you asked about growth hormone is what's based on his bone age, what's his projected height at this point?
Is something about 150 centimeters, which is, yeah, you can see it.
No bueno.
No, Michael, not at all. Not at all. Say it again. The parental height, target height, I have it right here, is 175 centimeters. So it's like a 25 centimeters. What is that, like a
Average
6 inches?
average height and a height prediction that's, -3 standard deviations or more.
Yes.
Ooh, that's a tough one. Are there any other questions from the audience or the panelists?
Yes. No, it's been the advancement of the bone age has been constant, like a 4 to 5 years since I got the kid. The first bone age I did when he was 8, and it was around 13. The second bone age that I did was when he was 9, and the bone age was 14. And the last one when he was 10. Now his bone age is 15.
And I'm assuming you had said that biochemically or, he had not been maybe had or there been issues with compliancy and so, but recently though, you feel like that he's adequately managed.
Good.
Seeing the androgens in 17-OHP.
Yes, they're down to normal levels.
Okay.
Yeah, over the last couple of years, they've been down to normal levels.
We have a question. Oh, Jeff, thank you.
Hi, this is Katie from San Antonio. Curious if you have growth spurt at all yet?
Yeah, not really. The growth rate has been constant, has been the same. I haven't seen a growth spurt going to 10 centimeters per year now. It's been 5 over the last 3 years.
And how has this been after the suppression on this therapy so far?
I cannot recall exactly, but I will say it's been okay. Well, he was in triptylor. The time that he was on the triptylor, he was fine. Again, the last time, I don't recall the labs right now with the LH, because there was some time gap with between the triptylor, the last triptylor injection, and now we're starting the Lupron. I cannot tell you from the top of my head what was the LH the last time that I measured.
Dr. Stillman, what are your thoughts on how much growth you might have left?
Probably, not a lot with the bone age of 15. I guess I'm wondering is, since his bone age is now surpassed 12, is it reasonable to continue suppression with GnRH agonists on him? Maybe with having a little bit of puberty and using an anastrozole, you might get a bit more growth on him. I guess if you wanted to look at it from what can I do at this point? Because the primary question is, is there anything that can be done for his facial stature? I think from my personal experience, I recall a patient years ago where I basically had the same thing. The patient was not well controlled and had a very, low height prediction, and I requested and got approval for growth hormone for idiopathic short stature, even though it's clearly not idiopathic. Why? But I don't know. From my standpoint, I would think that stopping GnRH agonists using the aromatase inhibitor and using growth hormone would be reasonable. We're not in a very long window where this patient could potentially, benefit, because it's unlikely that the bone age is going to hold at 15 forever. So that's my thoughts. Dr. Nunez, actually, you done some with. I'll call you out here. So you use aromatase inhibitors. Do you have any thoughts at this point about aromatase inhibitor and CA?
Dr. Stillman, you will pay for this. with CAH. I am biased in the aromatase inhibitor brand or generic form. I use letrozole more than anastrozole. And I select letrozole because for me, this is more potent than anastrozole. Some will argue with me, but my experience has been with letrozole. So that's why I chose letrozole. I don't use anastrozole. So going back to your case, I tend to start patients on letrozole at an earlier age. When I notice that the bone age is advancing, then I start them on letrozole right away. And because that's the only way that I have seen that where you can actually slow down the bone age advancement. In the CAH patients, I understand your dose of hydrocortisone is 20 milligrams. It's a very high dose. And there's only so much that we can do with that dose of hydrocortisone. But I try to push the hydrocortisone dose as much as I can. But the letrozole, and that's my message, has to be started a little bit early. As soon as you see the bone age advancing, start the letrozole. And I would recommend letrozole versus anastrozole.
Okay.
Hi, this is Raji Kumar, Dr. Munia's colleague at Austin. So, may not quite help your patient, but I just have to mention one of my patients who came with a similar history. I encountered him when he was a teenager, like 16 years or so, 15, 16. Again, came with an advanced bone age, came from a different country, a South American country, traveled elsewhere in Texas before the state was later Austin a couple years ago. What was actually surprising about him was the fact that his 7-year-old was very well controlled. And at no time did I encounter it high. And I saw him all of one month before the pandemic. And his exam was, I would have expected him to progress with he had a little before it's not significant. But on his exam, he actually had the bladder size was much smaller than what I would have expected. So he gave me the diagnosis of CAH. Long story short, several labs and products and stuff later, he ended up having that one in our organization. So I can't quite explain why his bone was that advanced, but he did end up starting testosterone replacement, so that's one NROE. And of course, he's in CAH treatment, so anything replacement is fine. I just thought I would mention it because as we started talking about him, and it was only 10, but then I heard that he'd been to early 30, so he obviously should have had pure gonadotropin at some point, along with the testosterone measurement, for which reason he used the tryptodone. But I just thought it was an interesting discussion. A similar hit rather than renal insufficiency, advanced bone age, but there was this zebra in there.
Was he obese, perhaps? Was that a factor?
Well,
Obesity can drive your bone age.
he was a little obese, but then he was also hypermobility. So he's great, and they still travel 2 hours to come see.
Thank you very much.
Thank you, Dr. Gomez.
There was a question in the chat. What is the predicted height, Dr. Meyer?
I believe you said it was like 150 or 155. Let me off my mask here. Let's see, do we have any cases? If anyone has any cases, we can cover that, or anyone else has anything else that they want to add.
Yes. Do you want to come up and present your case? Sure. I'm going to.
This case is that of an 11-year-old girl who was adopted from China. And she was referred to me because of a significant amount of clitoromegaly. I will describe her physical exam to you. She has breast development. She's about 10 or 3. And the vaginal area, there is fusion of the labia, so I could not see the opening. But the clitoris is about 5.5 centimeter, and the tip is bulbous, like a glans penis, and a little bit wide. It looks like an under-virilized male. So I went through differential diagnosis. I can give you some results. Her karyotype is 46XX. Testosterone is 29. 17-hydroxypregnenolone is about 70. 17-alpha-OHP is 40. LH is 5.6. FSH is 6.8. That's the data I have for you. She's 11. She's 11. Any thoughts? Not high. I cannot remember the number exactly, but in the ballpark of about 50 to 60. Clinical pathology lab. The DHAS or the rest of all the labs were done at clinical pathology lab. I need help with the signs of adrenaline. Oh, good questions, Raj. Good question, Rajni. I didn't tell you. There's no axillary hair, no pubic hair.
We'll just have to repeat those questions.
Oh, the question was if she has any signs of adrenaline. No. She has pilarchy and she is 10 or 3. No other signs of virilization.
How is her growth then?
She is actually, the question is, how about her growth? She's actually at the 70th percentile. I do not have information about height of biological parents.
They missed the cortisol level. If you repeat that.
The cortisol level? Where are the questions posted? I missed the cortisol level. I did not measure a cortisol level. My question is, why would you measure cortisol? Is there a thought on a differential diagnosis why you're interested in the cortisol level?
That was Dr. G.
And if I heard you correctly, I believe you had reported what sounded like mostly normal, not elevated androgens. Is that correct?
That is correct. All the androgen hormone levels were normal. Testosterone is 29.
Okay, sorry. So the testosterone is 29, but all the other androgens, 17-hydroxyprogesterone, the DHEA, sulfate, all of those were normal. And I'm assuming the patient has normal electrolytes as well?
Correct.
Okay.
Normal 17-hydroxypregnenolone, progesterone, DHEAS, electrolytes. I cannot remember. I don't think so. Because I was not interested in knowing what her bone age is. She's 70th percentile. She's not short. So I was not interested. And she's 10 or 3 in puberty. For an 11-year-old girl, that's perfectly normal.
You have a response on this to your cortisol.
The response to the cortisol, thinking about higher enzyme deficiency in the steroidogenic pathway with backdoor pathway, if all androgens are normal, will not be. Are you thinking about STAR?
You would think
In
that there'd
the-
be electrolyte abnormalities in that particular case, and the child would have presented much earlier.
Correct, if it is a STAR defect.
And did you say that the gonadotropins are like the LH on the assay?
LH is 5.6, FSH is 6.8.
Okay, so very few little gonadotropins.
Correct.
I apologize. We spoke about it last week. How about that finding in the
Okay, Rashmi brought up. I sent her for an MRI because I wanted to locate internal structures. So the MRI of the pelvis showed a hypoplastic uterus. It showed,
I apologize. On physical exam, you mentioned getting out in the right right.
okay, I'll mention that. MRI of the pelvis showed hypoplastic uterus. It showed a right ovary. The left, they could not see the left ovary, but they described a hernial sac that extended to the left labia. Inside the sac is an ovoid structure that they assume is the ovary, because they could not see the ovary in the normal pelvic region. But that's not guaranteed that that's an ovary. It's an ovoid structure. It could be a gonad with who knows what histology.
Did you say, were there chromosomes done on this young lady?
Yes, 46XX. Yes.
So the posterior labial fusion suggests that uterine exposure. But it's mom that had a lymphoma. Not clear, how long was the splenomegaly there? Recovery or a labial fusion really says.
She was adopted from China at age 7. So when she came to the US and came to live with the adoptive parents, they already knew there was clitoromegaly.
Maybe mom had a lymphoma or something.
Dr. August Park made a comment that the baby may have been exposed to high androgen levels in utero if, say, mom had a luteoma.
Explain the other gonad done in the right, because the ovary happens. Unless it's secondary.
Yeah, I'm not sure about that, but the normal androgen.
Yeah. That's right. Would be in utero exposure to androgens. Correct. Although the adoptive parents said that she was tested in China and they did not find any abnormality. They did not come up with an abnormal finding to explain the clitoromegaly. But going back to the MRI with the hernial sac, could it be that the hernial sac is just an incidental defect and has nothing to do with the clitoromegaly, with the etiology of the clitoromegaly? Yeah, and ovotestes. Correct. Yes.
I was curious, so why did you decide to do an MRI scan and having looked at the androgen receptor in some type of study?
No, the question is when I decided to order the MRI,
Why not a total ultrasound instead?
she was also ordered for a pelvic ultrasound, but for some reason they did the MRI first. She's having a pelvic ultrasound. Yes. And the other question is whether a skin fibroblast was done to check for androgen receptor, and no, I haven't done that. How many would pursue an androgen receptor defect? Testosterone is 29. That's why an androgen receptor defect or like an AIS did not come across to me with a testosterone of 29 and then normal androgens. Plus, and she has a uterus. So she's XX. So AIS is, or androgen receptor defect would not be in the differential.
You can see the plant is also has carrier part. It is not affecting the skin or the animal condition. So honestly, we have skin origin carrier type or something like androgen contact.
Dr. P, I think you have to come to the microphone because I think what you are saying will be beneficial to many people who are in this conference.
So I apologize. That's okay. I think I'm from here. Thank you. So what I was mentioning was, if you are considering a mosaic defect, we're only looking at the mesodermal origin when we're looking at the blood. We've not ruled out the ectoderm or the endodermal stuff. And as somebody pointed out, if you're considering an over-testicular dysgenesis, and we are seeing a phenotypic characteristic of a female externally, except for the genital area. So the question is, and there is one gonad which is seeming to descend in the groin. So is that a testicular, over testes? And the other one is the ovary. So I think we need more data about the genetic issue, potentially a skin biopsy or for sure. And I'd suggest also SRY to look for other, even though the karyotype did not pick up a Y material, but specifically looking for the Y material is what I would suggest. Thank you.
Thank you. If there is SRY, would you expect a testosterone of 29 or would you expect higher testosterone, especially 11 years old and pubertal with pubertal levels of gonadotropins? Sorry. I'm leaning in that direction too because. Okay, thank you very much.
Can we hear that recommendation?
The recommendation for possible action for the clitorman in this patient is in utero exposure to high androgen levels during the pregnancy. Thank you.
Okay, thank you all. It was we cobbled together and got, I thought, some very interesting cases. I don't see that we have any other chat or Q&A, and we're at 6:30 now, which is the end of the trainee session. So if you're here, there's a welcome reception. If you're not here, if you look at your phone or your laptop, you have, let's see if I can pull it up here. There is the lounge room, which you can find. So I encourage you all to pop into the lounge room. You can do some virtual socializing, pour yourself up a glass of wine or alcoholic beverage, grab the cheese and crackers, and we'll go ahead. We'll reconvene tomorrow and begin our main program. So thank you all again. Oh, wait, one more announcement from Dr. Bone.
One more announcement is before tomorrow, if you can get on the ICPE website and register. So for CME credits, we have till February 13th to register. Get on the ICP make an account, and then you'll be able to use a QR code tomorrow, and we'll give some more information on how you're going to get your CME. So, all right, see you in the morning.